Hey everybody, and welcome to the Sports Docs podcast. I'm Dr. Catherine Logan, and I'm here with my co-host, Dr. Ashley Bassett. And this is our Best of 2025 episode. 2025 has been a year of real growth for our show. We've seen our listenership expand, our community of colleagues grow, and our impact reach more clinicians, athletes, and sports medicine professionals. And this only happens because of you, our listeners who show up every week, curious and engaged and committed to elevating care in sports medicine. This year also brought a really cool milestone we're incredibly proud of. The Sports Docs podcast has been nominated for the Best Clinical Education Podcast at the Doctor Podcast Awards, which happened in January of 2026. That recognition reflects the quality of the conversations we've had and the incredible guests and community that make this podcast what it is. We're deeply grateful for the partners who also make this show possible. So a huge shout out to JRF Ortho and Arthrex for their continued support. And we're excited to have welcomed BraceLab as our newest sponsor. We're also incredibly grateful and thankful for the ongoing support of AOSSM, whose commitment to education and excellence aligns perfectly with our mission. We even have some exciting new adventures scheduled for 2026, but you're just going to have to wait, and we'll get more on that later. So this episode is a look back at some of our favorite moments, insights, and conversations from 2025. Episodes that challenged us, inspired us, and reminded us why we love this field so much. So let's dive into the moments that define 2025 and set the stage for an even bigger year ahead. Episode 137, Dr. James Voos and Dr. Alan Getgood, the ACL Glow Up. LET versus ALL live at AOSSM.
Yeah, it's been remarkable when you get their physical therapy reports or how they're doing, other than maybe a little bit of extra soreness that first couple days. I have not seen any challenges in coming off of crutches or getting their extension back or their quad starting, but I would agree with Al that early therapy is very important. And in fact, in our practice, once you schedule your surgery date, we schedule your physical therapy date 2 to 3 days afterwards. Absolutely. So it's an automatic, and really our surgical rehabilitation protocol has no difference. So the therapists know they can take it and run. Maybe do a little more deep tissue stuff over the lateral side to mobilize around the incision to soften it up, but that's really it.
Yeah. And they sometimes don't like the look of the wound, because you can't really close the full wound, and you shouldn't close the wound all the way distally. You're going to increase the risk of increasing contact pressures to the patellofemoral joint. And so you're going to have an opening, and if you're going to have an effusion, you're going to have a hemarthrosis post-op. It leaks out a little bit, so you get a little bit of swelling on the outside. You just need to reassure him it's going to settle, and everything will be fine eventually.
Episode 150, Overtime, Cyclops Syndrome after ACL Reconstruction.
So to sum it up before we get into our own little discussion on this, so Cyclops lesions are mechanical, not psychological, but the mental impact of limited motion is real. Hyperextension is an identifiable, measurable risk factor for development of a Cyclops lesion, and technical variables matter less than patient morphology and early motion recovery. But let's not throw out our surgical technical pearl babies with the bathwater. Keep putting your tunnels in the right spot, keep doing the right size graft, keep checking your notch for impingement. Doesn't mean we throw all that out, but there are factors that are outside of our control that we need to acknowledge.
Episode 138, Dr. Jorge Shala and Dr. Robert Parisian, Hips Don't Lie, How to Tackle Dysplasia, live at AOSSM.
Okay, so we do want to, start to talk a little bit about when do you choose that PAO. We talked a little bit about sharing with our partners and stuff, but what are the things that sort of, Jorge, make you say, you know what, I want you to see my colleague?
So borderline dysplastic, I had surgery already and failed. Always sees my partner. Okay. Anybody that has a positive fear index or a combined antiversion that is higher than normal, and anybody that has generalized laxity, I would have them see them. It has to be a very clear impingement indication for me for a borderline dysplasia, not to send it to him for a second opinion.
Great. Yeah.
Yeah. No. I'm exactly. I'm the same way. A frank dysplastic. Somebody that has a lateral center ridge angle of 12 or 14. Of course, that's gonna need a PAO. But now I would say that and the indication is exactly the same for me, but I would say that now we're seeing the combined scope PAOs. And so you're having, and I think you need to do the intra-articular work. So it's not necessarily just the PAO. You want to get in, you want to repair the labrum, you want to assess the articular cartilage, address that as appropriately needed. And I think a lot of us are finding that a hip arthrosis can do that a lot more efficiently, a lot better than doing it open. And then you can have your PAO colleague come in under the same anesthesia and do the PAO during that setting. Yeah. And some people can do both, like an Andrew Spiker, for example. But others they have a partner that comes in and does it after.
Mm-hmm. Episode 133, ACL reconstruction outcomes, factors associated with return to play and re-injury.
So we referenced this a little bit, but when we were talking about this episode a couple days ago, you mentioned this article that was recently published looking at preoperative grit scores and the impact on knee range of motion. So we did an entire overtime episode on grit and ACL outcomes, actually. That's episode 53, if you guys want to check it out. But Catherine, can you talk a little bit more about this article, specifically looking at the impact on motion?
For sure. I can't believe that was so long ago, 53. So
I
we
know.
are we're in the 130s now. So
yeah.
Time is
Cranking
flying.
them out.
Okay, so this article is titled Higher Grit Scores Are Associated with Earlier Increases in Knee Flexion Following ACL Reconstruction with Meniscus Repair, and this was in pediatric patients. So it was published in April of 2023. It was in the Journal of Orthopediatrics. And so HSS, they performed this study and they found that their patients with grit scores below the 50th percentile who are undergoing ACL plus meniscus repair had 5 degrees less total range of motion at 3 months compared to those with higher grit scores.
So, though 5 degrees may not seem like a lot, quicker motion recovery in patients with high grit may be a leading indicator that these patients' likelihood to achieve other post-op milestones and meet criteria for return to sports may be more quick. So, this obviously needs future study to see how grit impacts other factors like strength gains, passing, return to play assessments, etc. But Catherine, as you alluded to, and you will probably speak more on, if you're delayed in your motion, I always tell you, like, motion comes first, then strength, then function, right? If you're delayed in your motion, like, everything else is delayed. So are you seeing that? Like, what are you seeing with your rehab patients?
Yeah, I think, that's so true. It's like if someone has delayed range of motion, it takes them that much longer to get on the bike. And our bike is so important for like getting our quad endurance and our quad strength, like our early stuff before we can do a lot of like high impact. And it's like, so now we're starting a little bit slower there. And it's like every little piece of it just feels like a touch behind. And, like I said earlier, it's not like you can't catch up, but it takes a lot. And can that person turn up that gear, to like, if they're having trouble early, what can we do to sort of help them get that higher gear? So I know in our clinic, we do some, mental rehab sort of tools through the Unbroken Athlete, but we also just try and really get them in early and say, hey, you got this window to like get this range of motion, and now is the time, and sort of have a little bit of that tough love, which is hard because you don't want to come down on them. They're obviously, it's a lot, and you don't want to give them a hard time, but at the same time, you don't want to give them the advice that they really need to hear. So it's tough. And I know, Ashley, you're talking about starting to integrate grit and ACL RSI in your practice. And I think that, I think that's awesome.
It would be helpful to know, to be able to predict in some way which patients are going to struggle. So you could either keep a close eye on them earlier on, make sure that they're in with perhaps like a more aggressive PT. Maybe they're doing more PT visits. I know like you don't want to blow through too many PT visits because then they're self-paying on the back end, but to be able to like know this in advance. And so if like you can see, oh, this person has a low grit, like they might struggle with motion, especially if they have a dusted meniscus tear that I know I'm going to put together and limit their motion, which is going to limit their quad strength, right? How can I maybe intervene ahead of time? Because then if you don't, like they follow up 2 weeks and then 2 weeks, and then all of a sudden, wow, like you're only at 80 degrees of knee flexion. Crap. Now we've like missed this boat. Now we're doing PT 4 times a week and you can't do your strength gains like you would or any other person would. So I think being able to intervene early is going to be like the key. But you said like you don't want to come down on them, but at the same time, like I used to tell people like, all right, take your time, you'll get there. Like we have a narrow window to get back motion, and I feel like if you don't get it back, then everything else suffers thereafter.
Episode 140, Dr. Gabriella O'Day and Dr. Brian Waterman. Shoulder Wars, Return of the Cuff Tear, live at AOSSM.
The last thing I want to wrap up with is recovery, rehab, and recovery after. And let's go back to revision rotator cuff, because I'm curious to hear your thoughts on this. Because, the sling immobilization, how long, when to start PT after primary, I feel like it's kind of like, it's surgeon dependent. But with a revision, how do you change your recovery? Do you keep it in a sling longer? Do you delay the onset of PT? What do you do to protect that repair?
I think you just have to have clear guidelines. For me, the longest I'm keeping somebody in a sling is 6 weeks. And that's with a primary repair that's big, so a large cuff tear, or in a revision setting. But I do have very clear guidelines with patients when they come out of their sling. And I think that's just a quality of life thing that also helps. So for me, if a patient is, seated in a chair and they can put their arm in a neutral position, I tell them explicitly, come out of your sling. Because so much of the pain profile is because they're hiking their shoulder up, their traps hurt, and they're like, I'm in this for 6 weeks, this is miserable. And then also, if their hand is on their belly, they're also contracted, and then they're more likely to also have some, anterior capsular contraction that you're having to work through afterwards. So as long as they can keep their arm kind of comfortable, then I'm pretty liberal about the sling in that setting. But if they're up and walking around, they're in the sling. And they're sleeping in the sling. If they leave the house, they're in the sling. And so, if I'm not doing anything to their biceps, I tell them, come out of the, stretch your elbow out. PT for me, I start them early, but they're not doing much early. I just want to make sure that they're building a good relationship with their therapist. They're going a couple times to know what are safe movements to do in that first month or so. They're getting some pain relieving, modalities as well. And I tell them the work starts at, 6 weeks, around that time period where you're going to be doing a little bit more at that time. And I think that early counseling is helpful to patients, so they're not like, hey, I'm incapacitated for 6 weeks. Right. And I tell them, I'm like, hold a coffee cup in that hand. Like just do something where you can feel a little bit more normal.
Go take a walk.
Yes. So I think it helps.
Any additions to your rehab?
Yeah, no, I think it starts with an early discussion with your therapist. Obviously, you've been in the shoulder. You can communicate the risk profile, and so we have several different algorithms. We go with a conservative profile. I say this is a massive, irreparable one with subscap precautions, so let's proceed cautiously. And then there's, it's kind of like the angel on one side, the devil on the other. I have these two voices in my head. I just want to immobilize them. I want to get good scapular mechanics. But at the same point in time, I have our therapist constantly chirping in my ear about, active, assisted, pendulum-supported exercises are completely safe. And you do want to get some muscle activation that may have some ability to potentiate healing process. But I try to individualize it.
Me too.
And I don't know if the right answer. I'd be interested in hearing what you ladies think.
No, I agree with a lot what was said. Like, I really want people, I do get in PT early, even though there's not that much to do in the first 6 weeks. I think a couple things. You get the safe movements. You get, you're starting to avoid that upper trap, sort of like scapular hiking that they all love to do. It also, I think, mentally, just sort of helps to get them, okay, I'm out of the house, I'm starting to do things. I think there's plenty of stuff that they can do that has nothing to do with their shoulder. So that's something we encourage a lot, is like, I would love for you to go to the gym. I'd love for you to get on the stationary bike, like, all those sort of things. I like that.
For me, I think it depends on how many visits of PT they get too. True. Because I think, especially with the revision, they're going to be in PT for so much longer. So if they have a great number, then absolutely. I agree with everything you guys just said. Get them in, get them doing cervical spine, conditioning, safe movements, like you said, building a relationship. If they're limited, I actually delay the start of PT to 4 weeks with a revision, just because I feel like they're not doing very much up until that point. And then, like, recently, especially for revisions, I'm a big fan of the BFR, the proximal BFR. I just feel like it releases growth factors, and it can help with some of that muscle that's been re-traumatized, and people are doing pretty well with that. So I think
we had Eddie Chang on, and he was talking about that, like their work that they're doing, with just contralateral BFR, and it's interesting.
So
I
is,
think,
cool.
I think therapy also has the potential to establish the guardrails on your relationship. And, the do's and don'ts, I always say, we want to feed the beast. I want to give you something that you can do so you don't get tempted into the forbidden zones.
Episode 135, Dr. Maninder Kokar and Dr. Lauren Redler. Guardians of the Growth Plate, Physeal Sparing Knee Surgery, live at AOSSM.
For our listeners, when we talk about ACL reconstruction in this age group, there's three broad categories, whether we're as far as the growth plate. So as far as physeal sparing or partial transphyseal or complete, Lauren, can you talk us through, in those three categories, how do you work through those? What are your different indications, and how do you decide what your preferred technique is going to be?
Yeah, absolutely. So with the skeletal age cutoff that I was mentioning before of boys of 14 and girls of 13, that's when I would feel comfortable going across the growth plate with a soft tissue graft, of course, and not having any bone going across that growth plate. Because I drill outside in with a flip cutter, that is going to be a little bit more of an oblique socket on the femur, so a little bit more of an injury to the growth plate rather than transtibial drilling with a more vertical tunnel. And so giving those kids a little bit more time to grow before going across that growth plate. I think anything younger than that, I love doing the iliotibial band, modified Macintosh that I learned at Boston Children's from Min. I think that there's a sweet spot kind of in between those two, especially for savvy parents that are concerned about growth, and maybe it's okay to go across their growth plate, but if you can avoid it, especially on the femur, that's a nice tool to have in your tool belt to do a hybrid technique. And as long as their epiphysis is big enough to keep that graft all epiphyseal on the femur and going across the growth plate on the tibia, I think that's a nice kind of tweener technique to have.
Yeah.
Episode 114, Overtime, Rehab after MPFL and TTO.
In terms of complication rate, the rapid group had a significantly lower overall complication rate. The incidence of patella baja was 0% in the rapid group compared to 17% in the control group. And interestingly, surprise, this decrease in patellar height was seen in the control group that occurred between 1 day post-op and 6 weeks post-op and persisted until the final follow-up. So this suggests that the first 6 weeks after surgery are really critical for rehab, and missing this window may increase the risk of lower patellar position and subsequent development of anterior knee pain.
That's so interesting.
I know. It makes sense though, right? If you're not moving, you're going to get scar tissue, and then you're going to get baja. But it was really interesting that it didn't change.
Yeah.
After 6 weeks, despite what they did in the range of motion, it didn't change at all.
I know. It almost reminds me of extension range of motion. If you don't get it right away, it just becomes to get. Whereas flexion, we always feel we have this window and we can keep pushing. Yep. But yeah, it's really that's such a good nugget.
Episode 139, Dr. Michael Bamfey and Dr. Christopher Camp. Pitch, please. Managing UCL injuries in throwing athletes, live at AOSSM.
So we mentioned rehab protocol as part of the non-operative treatment regimen, but injections have also been described, specifically PRP. So Chris, what are your thoughts on the use of PRP for the non-surgical treatment of UCL, and how does that change the recovery for that patient?
It's a great question. Unfortunately, we don't have any clear evidence to tell us the right answer. I've been involved in a few studies on this, and almost all of them end up being equivocal. So there are some studies that say it can work, but we don't have any really good head-to-head comparison studies saying that it is better than non-operative treatment. So for me, I don't use it in most patients, but I do think there may be a role for some of those partial thickness proximal tears, particularly if you have a patient that really wants it and is really buying into it, or if they've had success with PRP elsewhere in the body, then those are the times that I really, really think about using it.
Yeah, and some of the data actually has shown that they do worse. They're more likely to require surgery if they've had that PRP injection. So similarly, I do not use it routinely. I think that for the muscular injuries or the tendon injuries, the flexors, I think that they could have a role with that. If you translate the data we have from tennis elbow on the outside of the elbow, I kind of use that for the inside of the elbow as well.
Episode 153, Dr. Sarah Edwards, The Thrower's Shoulder, Part 2.
All right. So we want to wrap up the partial cuff injury section with talking about return to play. So our first paper for this episode reviewed the rate and timing of return to play after arthroscopic rotator cuff repair, finding that approximately 75% of athletes were able to return at an average of 6 months postoperatively. So Sarah, for your throwing athletes, how do you counsel them as far as when they're going to return to play, as well as what they should expect about their performance? So velocity, do you expect that they'll get that back?
Right. So I think you have to really caution them that they may not. All right. And then again, it's a last resort option. You may not be the same athlete and maybe only 15 to 20%. There's one state I think should 40 to 50% could get back, but I tend to err on the more conservative side when I'm talking to him. And that, we're doing this to just give it a chance. And then, I'd say minimum 6 months, but more likely in the night, particularly for a thrower, if it's their throwing side, it's going to be longer than that. And so I tend to be pretty conservative.
Episode 136, Dr. John Kelly and Dr. Matt Fury. Bankart like Beckham, Mastering Instability Surgery, live at AOSSM.
Well, you bring up what we want to discuss next, which is, when do you start? There are some people out there that go to the Latarjet right away.
Yeah.
We actually had our mentor, Mark Price, on the show, and he was speaking about like his experiences and taking care of like professional athletes that he would, an NHL guy that would come in. It was like they wanted the Latarjet because just like culturally, that's what they were doing in a lot of the European players. So, if the Boston guy is like, but my Swiss teammate, this is what you do. And whereas like the NFL, they weren't starting with those types of procedures. So I don't think anybody here at the table is really going to the Latarjet as stage one and someone that doesn't, have extensive bone loss. But, what do you think the merits are of going to a Latarjet first?
Jara Fortho, Restoring Movement Together.
Well, I think you're definitely going to sleep better at night. But I always have that question in my mind, is this best for this person long term? Because I know that the studies, Hovelius is a little bit controversial, could be dislocation arthropathy, but I think there's an inference, shall we say, in literature that Latarjet maybe can potentiate arthritis. There's a study by Peter Millett, though, that makes me always question the value of just going to one bulk thing, because even Peter Millett's hands, one of the best surgeons in the country, he had about a 23% resubluxation rate, and he writes in his discussion, perhaps the Hill-Sachs lesion should be addressed. So I wonder maybe if the Cadillac operation would be maybe beach chair, do the remplissage, and then do the open Latarjet or Latarjet, whatever you like it. Because I think to do a Latarjet, you're requiring, as you said, Matt, a long enough coracoid to enlarge the tract so it doesn't engage, right? And sometimes I've been there where I've opened up and it's like the coracoid's puny. I'm like, yeah. So I think you always say, what can I do in my hands that treats the pathology with the least morbidity? That's my goal.
Yeah.
That's what I try to do. So it usually ends up being remplissage with auto bridge, but you got to be humble and you got to know, well, if you see a really inverted pair and a high contact athlete, I'm going to do a Latarjet.
Yeah. Makes sense.
It's certainly a powerful procedure, and there are places that do it first line. That's just not very common here in the U.S. It's not common in my practice. But there are patients that you meet for the first time that happen to have those problems that are tough. The one that we're talking about this morning, nighttime dislocations multiple times a month. And so you find those patients, but I agree. I don't think it's not what I want to do the first time I meet a patient, but sometimes you feel like you have to.
Episode 144, Dr. Travis Matheny, Management of Borderline Hip Dysplasia, Part 2.
And once again, I always go back to my own life experience. Like, I recognize that not all mildly dysplastic hips have to have a big surgery to correct them to get a long-term benefit. That said, I think we're still struggling to figure out who does and which hips need more. When I talk about the PAO, and my discussion with the patients is, look, there's non-op, there's scope, and then there's PAO plus or minus the scope or orthotomy to address whatever label stuff you got. And each one are safe. They're medically okay to consider. No one's going to fail me on my board exam if I tell you to do one or the other, because you have a condition that's not life-threatening. There's data to support each one of those paths. So if we think, well, what's beneficial then of a PAO or arthroscopy? Is there truly a study that shows that arthroscopy or PAO is going to beat arthroscopy? And I don't think that's ever going to happen, honestly. We're trying to look at that in the anchor group. We're and indirectly, but no one's ever going to know the denominator. And getting an accurate comparison of apples to apples in somebody that's going to do arthroscopy versus PO, it's just going to be hard. And if for nothing else, when I talk to patients, I tell them, look, I like to win. But the win, honestly, in these situations for me is after we give them all the information about the non-op, but then also the different surgical options and what the data seems to show so far as benefit, that they get to go home and think about it. And then the win comes when they choose their path. And then on the far side, whether it's going awesome or they're still struggling with whatever PT part or something still aches a little bit, whatever, they can still look back and say, yeah, but I made the best decision for me. This made the most sense.
Episode 142, Dr. Jacob Kelsey, Wearable Technology for Athlete Performance and Injury Prevention, Part 2.
So we want to talk about a study that you're currently involved in. It's an ongoing study looking at the use of wearable muscle oxygenation sensors to improve return to play assessment after ACL reconstruction. Obviously we've spoken a lot about this on the podcast. We use external parameters to guide return to play, like functional analyses and strength testing and patient reported outcomes. We haven't really used internal physiologic parameters like muscle oxygenation until now. So first, what motivated you and your team to look at this as a marker of recovery after ACL reconstruction?
So thanks for talking about this one. It's one's definitely near and dear to our heart. It's been a sort of big project that we've put a lot of love into. And AOSSM supported it. So we got one of the Playmaker grants for this one, which has been really cool. We presented it at the NFL Physician Society meeting at the Combine and won the award for that. And so this one in particular, it's really interesting. So when you're thinking about ACL recovery, one of the things we worry about a lot is the quad, right? And so can we get the quad up? Is the quad firing well? Is it firing properly? And there's not a lot of good ways to look at that other than, with your eyes and just be like, can you fire your quad? And you feel it like, oh, it feels good, And so this was a way of getting an internal measure of sort of what's going on with the quad and using muscle oxygenation. We put the sensor on the VMO, so it's a MOXIE sensor. There are a couple other sensors that'll look at muscle oxygenation, but this seemed to be the best one and sort of easiest to use for us and a little bit the most reliable. So we're putting it on the VMO. We're putting it on both sides. So we first did we took a look at sort of healthy controls. Are the right and the left, so are comparable? Is the dominant side comparable to the non-dominant side? And the answer was yes, pretty comparable in terms of muscle oxygen uptake. And so then as we look at our athletes rehabbing and coming back from an ACL, we checked them at 6, 9, and 12 months. And it really is amazing the huge variability in not only, the athletes and how they do, but also the big difference between some of our measures that we would consider objective measures that we're sort of looking at their return to play and then looking at their muscle oxygenation uptake, and you're like, oh, well, they're really lagging behind much more than we think. And maybe they're not there yet. And we have not proven that is really a sort of a reason to hold them back. But I think we're trying to get as much of that data as we can looking at it. The interesting thing is we've had a couple on revision cases where we took the contralateral BTB, right? And we'll sort of look at both sides. And oftentimes the harvest side is the slowest to recover, more so even than the ACL reconstruction side. And so, are we the harvest is obviously impacting them. Can we make that a little bit sort of smoother and decrease their risk of having the quad shut down? And how can we kind of maximize their ability to recover? But I will tell you, when we're looking at it, the professional athletes and the high school athletes are very different. The professional athlete at 6 months is probably where the high school athlete is at 12. And so, as the younger athletes in particular, really trying to sort of drag out their rehab to get them as close to that, sort of 10, 11, 12 month mark. It's not really the, 9 months and you're good to go. It's really, we check all these parameters. And this is just another data point that we're looking at, right? We have amazing physical therapists. We still totally rely on them and their return to play protocol to get there. But this is another metric that we're trying to incorporate, which I think really helps.
People are staying active longer than ever, but thumb CMC pain can stop that momentum in its tracks. That's why the Push MetaGrip from Bracelab is changing the game. Unlike traditional treatments that lock you down, the MetaGrip provides stability without sacrificing mobility. You keep your grip, your strength, and the freedom to do the things you love, whether that's playing sports, working out, or simply staying active day to day. Expertly engineered in Europe in collaboration with a world-renowned hand therapist, the MetaGrip has become the gold standard in thumb CMC care, helping people not just manage pain, but to keep moving with confidence. Learn more at bracelab.com. Clinicians, you can request a free sample by emailing samples@bracelab.com and mentioning the Sports Docs. Thank you for listening to this episode of the Sports Docs. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or a comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod. We love your feedback.